Hello everyone. In continuation of the previous topic that we discussed about the basic evaluation of a child with developmental delay, in this presentation we'll be taking up three cases to understand the subtypes of the developmental delay and a systematic approach to their evaluation. So, the first case is of child A, and as we can see that this child is a 9-month-old boy. His parents had brought this child because he was unable to sit without support. He did not actively reach out for the objects and he cooed but did not babble. So at 9 months of age, the expected milestones would have been that he should have already started sitting without support. He should be having at least immature pincer grasp and he should be having bisyllables. There was no loss of skills. He, however, stands erect when supported. So that means that probably he had extensor hypertonia of the truncal muscle. How would you analyze this patient? So clearly we had a motor delay in this child, and along with that there was a language delay as well. So this was a child with global developmental delay. And anything else we needed to know about this child? Yes, he had delayed cry at birth, he had seizures on day 2 of life, and he had poor feeding in the first week of life. So all this indicated that he had neonatal encephalopathy, and on top of that he also had tonic seizures once every fortnight. So he had associated generalized epilepsy. He also drools constantly. Although slobbering may be present, normally also till 12 months of age, but constant drooling will still be abnormal and it may be a pointer towards the pseudobulbar palsy. He is constipated on most days, which is a common association of the spastic quadriparesis if the patient is having, but he had no sleep onset problem. So exploration of the comorbidities also we did. So etiology possibly was perinatal asphyxia, and we explored comorbidity of the pseudobulbar palsy, epilepsy and constipation. So we came to this diagnosis that this child was possibly having static encephalopathy with global developmental delay, with developmental age of less than 2 months, with spastic quadriparesis, with microcephaly, with epilepsy, with pseudobulbar palsy, with constipation, with possible perinatal insult. When we did EEG for this child, it showed burst suppression pattern. So why did we choose to do EEG? Because he had epilepsy. And we already had the results of newborn screening where the thyroid profile was normal. So we did not go ahead with the rest of the metabolic screen. And since from the history suggestive of perinatal asphyxia, it was likely that there was an underlying structural cause for the global developmental delay, we proceeded on to get a MRI brain then. So in this MRI brain, we got lysencephaly with HI sequelae because there was poorly formed Garai and sulci, that is pachygyria. Along with that, there were white matter changes and there was paucity of white matter in the posterior head region. So that was indicative of superimposed HI sequelae. And so this came out to be a likely lysencephaly. So there are so many genes also associated with lysencephaly, but parents have refused further genetic workup. Coming on to the case 2, a case of child Y. So this child is a 7-year-old boy who presented with frequent falls and delayed motor milestones, and this problem was increasing progressively, so that now he was having difficulty in getting up from the sitting position. There was, however, no diurnal variation of weakness or any ocular, facial or bulbar weakness. So what does all this indicate? So delayed motor milestones to begin with and now having progressively increasing difficulty. So maybe there is an ongoing process. No diurnal variation of weakness and no ocular or bulbar weakness indicates that possibly the localization of lesion is not at neuromuscular junction, and there was also no facial weakness. Then again, there was no sensory complaints. So it looks like purely a lower motor neuron type of problem. And his other milestones were as per chronological age. So the language and the social milestones were normal. There was no positive family history. So how do we proceed? This age, 7-year-old boy with predominant motor delay. So we proceeded on to examine. He had normal faces, his head circumference was normal, there were no tongue fasciculation, his fundus was also normal. But he had lumbar lordosis, he had waddling gait, he had hypertrophy of the calf muscles, biceps and tongue, he had a positive Goward sign and Valley sign with decreased muscle stretch reflexes with proximal more than distal weakness. But there was no ocular, bulbar or facial weakness or foot deformities. So what does that indicate? That there is possibly a lower motor neuron type of lesion, and since the stretch reflexes are decreased but they are not absent, it is less likely to be at the level of peripheral nerve. Also there is hypertrophy of the calf muscle, so likely to be a muscle involvement, especially waddling gait, proximal weakness. So again this points towards the possible muscle problem. And since this problem is ongoing progressive problem, it is likely to be a dystrophic process. And so since this is likely to be a muscular dystrophy with predominantly developmental delay preceding that in a male child, the most possible etiology looks like Duchenne muscular dystrophy. So in the examination we had this calf hypertrophy and this valley sign. So how do we understand this valley sign? So in the valley sign, the child is asked to stand with his back towards us. Then he is asked to abduct his shoulder up to 90 degree or as much as possible, and he has to then flex his elbow to other 90 degrees, so that then angle is made like this. And then we look at the deltoid and we look at the infraspinatus and the posterior axillary fold. So if there is hypertrophy of the deltoid and hypertrophy of the inframedial fibers of infraspinatus and atrophy of the supralateral fibers of infraspinatus which constitute the posterior axillary fold, this is considered as a positive valley sign, and this may be present even when the calf hypertrophy is not present, and it is quite indicative of Duchenne muscular dystrophy. So historically and examination wise, the etiology was pointing towards DMD, although there was no positive family history. It has an X-linked recessive inheritance, but sporadic DMDs are also known. So we got the serum creatine kinase done, which was very high, more than 11,000, and multiplex ligation probe assay for dystrophin gene showed deletion of exon 53 to 54 in dystrophin gene. This was consistent with the diagnosis of dystrophin related muscular dystrophy. Coming to the last case, X, a 2-year-old child. So this child came with another possible complaint of a different subtype, that the child cannot talk. So once we have this particular complaint that he cannot talk, again we would take this in detail. So the child had started babbling at 8 months. He spoke 1 to 2 meaningful words by 1.5 years, and thereafter there was no further gain. He used mother's hands to communicate needs. So this hand on hand holding to indicate towards object is immature pointing, and if it is to indicate the needs, it is called as proto-imperative pointing, whereas if this kind of pointing is used to point at the other objects which he may not actually need, it is proto-declarative. Normally the proto-imperative and proto-declarative pointings are used in relation with the index finger pointing, and this hand in hand pointing is not an index finger pointing. This is an immature pointing which indicates that the non-verbal communication is impaired. Then we explored the social domain as well. He developed social smile at 8 weeks, never waved bye-bye, was engrossed in solitary play with car wheels. So he was focused on part of the objects rather than the whole object, and his even the social domain in addition to the language domain was delayed, whereas the gross and the fine motor domain were age appropriate. So there was a dissociation between the physical and cognitive development with marked impairment of social and language skills. So he was born as a product of non-consanguineous marriage with normal antenatal and perinatal period. There was no history of seizures. He had tendency to spin. There was no vision or hearing impairment or ear discharge. He had difficulty in sleep onset. He was also very fidgety and restless, but there were no feeding problems. So we explored the other things. So there was no epilepsy, no sensory issues, but there was a problem of hyperactivity and sleep onset problems. So on examination, what we found that the child did not have any dysmorphism or neurocutaneous marker, and particularly we did the Woods lamp examination also, which came out to be negative, and ear examination was also normal. Head circumference was normal, his nutrition was fine, but he had poor eye contact. He had tendency to spin in the room, mouthing of fingers was there repeatedly. In the higher mental function also, we found that he was very restless but aloof, lost in his own world, and he was producing some idiosyncratic animal-like sounds. Rest of the neurological examination was normal and systemic examination was also normal. So what could have been the differential diagnosis? The differential diagnosis could have been either there is input problem, there could have been undiagnosed hearing impairment, or maybe the child was not exposed to a language rich environment. So we really need to explore the social context of the language problems as well. So, and otherwise it could also be a developmental disorder like autism spectrum disorder, or it could have been part of global developmental delay, or it could have been part of acquired epileptic aphasia, which is Landau-Kleffner syndrome, and it could have also been an output problem like a speech articulation disorder or a developmental language disorder. But from the history itself, we have seen that there is no epilepsy, so LKS is less likely. GDD, it is not there because the gross and the fine motor are normal. There is actually no word production, so why it will not be an articulation problem? It is a problem with the language itself. So what it could have been? So we found that most of the other conditions we have ruled out, and we got a hearing evaluation done which came out to be normal, and so we applied a screening tool for autism, that is modified checklist for autism, which came out to have a score of 10. So the 10 is at high risk for autism. So this child was referred for further evaluation. So what testing do we do further? So the recommendations by American Academy of Neurology and Pediatrics and American College for Medical Genetics, they all say that if in all children with autism spectrum disorder, one must go in for chromosomal microarray. If it is a male with autism spectrum disorder, we also need to get one fragile X screening. If we have a trisomy 21 or other chromosomal anomalies where we have a strong suspicion of chromosomal anomalies, then the high resolution G-banded karyotype could have been done, which was earlier recommended as a investigation of choice. This is no longer the investigation of choice in the children who do not have any dysmorphism and no suspicion of chromosomal disorders. Then they say that if it is a female child with microcephaly with hand wringing movements, we need to do MECP2 testing to rule out Rett syndrome. And if it is a boy with autism with macrocephaly and pigmented macules on the penis, then sequencing and deletion or duplication analysis of P10 gene needs to be done. In fact, there is now growing evidence that there may be a role of whole exome sequencing in all children with autism spectrum disorder, which will increase the yield further of a possible clinical and etiological diagnosis. What is the role of other investigations? In fact, metabolic testing is indicated only if there is clear-cut regression, hypotonia, recurrent vomiting, lethargy, hypoglycemia, coarse faces, other organ system involvement, seizures or ataxia. In addition, uh, it could also be, if one decides to do a metabolic testing, it should include the complete blood count, a liver function test and kidney function test, lactate, pyruvate, amino acid, acyl carnitine profile, urine organic acid and urine glycosaminoglycans. If there is mica, go ahead with blood lead. And MRI brain actually is not routinely indicated, but it is to be done only if there is suspicion of what? Of either the tuberous sclerosis complex or other neurocutaneous syndromes or microcephaly, or if there are strong neurological findings like unilateral findings, or there is spasticity, or there is severe hypotonia. Okay, so and if there are clinical seizures, then only one needs to do an electroencephalogram. There is no role of routine screening for celiac disease, allergy testing, intestinal permeability studies, vitamin and mineral deficiencies or stool analysis. So for this child, DSM-5 was applied. So actually the diagnosis is purely clinical. There are no blood or investigative approaches for confirmation of ASD. It is confirmed clinically, and other investigations are only for the etiological purpose or comorbidities purpose. So we did a childhood autism rating scale also, which indicated that the child had moderate severity, and the chromosomal microarray and screening for Fragile X syndrome was done for the child, which came out to be negative, and the child has been taken up for the comprehensive behavioral and speech and occupational therapy program. So that should be the investigative approach. If we have a global developmental delay, then based upon the possible etiology of the underlying cause, like if there is a possible structural cause, we go ahead first with a MRI brain. If there is a possible genetic cause, like family history of 2 or more male children affected, suggestive of X-linked intellectual disability, we go in for specific targeted genetic testing. And if there are high clinical suspicion of metabolic testing, we go ahead with metabolic testing first. But if there is no clear-cut criteria, then we first do the genetic testing in the cases of global developmental delay, and if they are non-contributory, then we go in with MRI with MRS, and if they are also not contributory and there is suspicion of metabolic, then only we do a metabolic testing. So that is the approach in the case of global developmental delay. In the case of motor delay, depending upon where is the localization, we choose the test. Since this case was a case of muscular dystrophy, we went ahead with the DMD gene deletion. Otherwise, we can titrate or individualize according to the suspicion, clinical suspicion. And in autism also, we have discussed that there is no routine role of neuroimaging or metabolic testing, but genetic testing is to be done in all the cases. I hope this is useful to everyone. Thank you very much.